Welcome to Health Chats with Abington Health. I'm Luann Kahn. I'm the Director of Career Services for Temple University School of Media and Communications, and I'm thrilled to be your host for Philadelphia Magazine for tonight's web chat. The web chat is sponsored by Abington Health in partnership with Philadelphia Magazine, and our topic tonight is preventing health disease. Tonight's web chat, we hope, is going to help take you through the steps what you need to do all through your life, your 20s, your 30s, your 40s, 50s, and beyond, to keep your heart in really good shape. And tonight we're talking to Dr. Andrew Fireman, who is a cardiologist at Abington Health. Thank you to everyone who's already submitted questions for tonight's health chat. Before we begin, I want to remind you that during this chat you can continue to ask questions. All you have to do to submit your additional questions is go to that text box right below the video, and all the questions, by the way, are going to be kept confidential, so don't be shy about this. We also encourage you to invite your friends tonight to join us. Log on at any time during the chat. You can do this by sending the link to the Health Chats webpage via Facebook, email, or Twitter, and make sure to stay until the end because the topics will change based on the questions that are coming in. So, okay, Dr. Fireman, you ready?
All set.
All right. First, tell us a little bit about your background and your expertise.
Well, first I'd like to thank Philadelphia Magazine and Abington Health for having me on tonight's webcast. I'm a Philly guy, went to Jefferson Medical School and did my training at both Hahnemann and Medical College of Pennsylvania, and I've been in practice since about 1994. And I've been practicing general cardiology with special emphasis on echocardiography or cardiac ultrasound at Abington for the past 10 years.
Let's start with some general questions about heart disease. What are the most common types of heart disease?
Well, we get this question a lot, and I find that a lot of people kind of just call it heart disease when there's really lots of different types of heart disease. So when I'm seeing patients, I think of valvular heart disease, electrical heart disease or cardiac arrhythmias, coronary artery disease, which is usually the one that gets a lot of attention for patients coming to the office for prevention, congestive heart failure. Those are the major topics of heart disease that we see.
And are these some of the different stages of heart disease also that you just mentioned?
No, I think each category of heart disease has beginning stages, middle stages, end stages, mild severity, more severe stages. So we categorize severity of each one, but you really have to keep straight what you're talking about.
All right. So are there common ways to detect heart disease?
Well, again, we're talking about general heart disease, but if we were talking about coronary artery disease, one might go through testing such as stress testing or angiograms or CAT scans, and there's ways to detect less or what we might term subclinical heart disease with coronary calcification scores. In valvular heart disease, echocardiography is a very standard and very common way of analyzing for valvular heart disease. With congestive heart failure, we use echocardiography quite often. With arrhythmia heart disease, EKGs, rhythm monitoring, and there's also lots of different invasive tests that we will use from time to time.
I guess one question everyone wants to know are what are the basic symptoms of that you have a problem?
Well, in general, when we're talking about coronary artery disease and heart attacks, things of that nature, symptoms of exertional chest discomfort, easy fatigability, exertional heartburn, jaw discomfort, back discomfort. I get very concerned when I hear patients are becoming very sweaty and clammy when they're having symptoms. That really is an indicator to me that that this is something that raises a lot of concern. So those are some of the symptoms that one would look for: shortness of breath, symptoms that don't go away, that are triggered by exercise but aren't necessarily relieved with rest. Chest discomfort, back discomfort, jaw discomfort, teeth discomfort. These are all symptoms that get people's attention.
You know, I've heard a lot recently about the different symptoms that men and women have. Can you talk about that?
I think of this comes up a lot of emphasis on women and heart disease, and women will. I personally think of a lot of the symptoms the same. I'm looking for sort of patterns and certain types of ways that patients describe symptoms, but I think for a woman who may be experiencing some cardiac or heart type symptoms, oftentimes there's a lot more of, they're not quite as typical as, you know, the elephant on my chest or the brick on my chest. There might be more of a shortness of breath, or maybe some shoulder discomfort, or maybe some neck discomfort, or maybe an indigestion type feeling. Men can have these symptoms as well, but there is more of an emphasis, I think, in women to be very on guard and on the lookout for these more subtle types of symptoms, not just this awful feeling on your chest where something, you know, seems to be very, very wrong.
Okay. At times I've heard that that heart disease can be genetic. Is that correct?
Well, there is clearly, with coronary disease, there's clearly a genetic component. When we're assessing patients for their risk of having heart disease and future cardiac events, you know, having a family member, a male family member that has an event less than the age of 50, having a female family member having an event or a diagnosis of coronary disease at less than the age of 60, clearly, you know, is something to think about. There are other sorts of non-coronary artery disease genetic considerations. Something like long QT syndrome is something that's directly passed from parent to child. Some of the heart muscle disorders or cardiomyopathies are genetic in nature.
Okay, so what are some of the ways to treat heart disease? I come to you, I've got heart disease. Give me the range of possibilities. I know, it's a lot, right?
Very broad question, and it really comes back to what type of heart disease are we dealing with? You know, are you coming in because you're concerned about your family history and you want to, it's a preventative evaluation, and we'll go through a risk assessment and then maybe do some testing or initiate some therapies to reduce that risk. If you have valvular heart disease, we may do some echocardiographies periodically to assess the severity of a valve that may be not opening properly or leaking, and we may assess symptoms and assess heart muscle function. If we're dealing with congestive heart failure, we treat that with various medications, sometimes devices, ongoing assessments with cardiac ultrasound to check heart function. So there's lots and lots and lots of cardiac tests and treatment, and it really is very specific to the underlying specific cardiac condition that one patient may have.
Is it possible to get rid of heart disease completely, or is it something you always live with once you've been diagnosed?
I think of heart disease as it's really, in large part, something that I think the American and a more affluent society has to deal with long term. I don't think it's something you can just, for the most part, just prevent and not get. A lot of things we will just, for instance, hypertension. We will all pretty much get hypertension as we age. The vessels get stiffer and the pressure tends to go up as we age. I was just watching some reviews, and the reviewer says, I hope I live long enough to get hypertension. It was inevitable in his mind. And I look at many heart diseases as that way. I think what we're trying to do is we'd love to prevent heart disease, I think more importantly in my mind, I want to prevent heart events. I think we can live with a lot of the conditions in a chronic nature. We would like to prevent as best as we can the heart attacks and the strokes and the episodes that bring patients to their to medical attention.
I just want to say again, we're talking to Dr. Andrew Fireman, cardiologist with Abington Hospital, and if you're just joining us, you can still ask questions just by going in the text box, and some questions are coming in now, and this is one for you, Dr. Fireman. Please explain the process of how a statin slows cholesterol production by the liver.
Well, statins affect the liver by modifying the way cholesterol is processed by the receptors. So it actually enables more cholesterol to be taken out of the bloodstream and excreted, and without getting too detailed, it does lower the production of cholesterol and enables the liver to take up more of it.
Okay, here's another question, and again, we kind of touched on this before, but a viewer says, my father had a heart attack at age 50. I am 42. What can I do to prevent myself from having a heart attack?
Well, this is, I think, getting an evaluation with, it could be a cardiologist, it could be your primary care physician. It starts by really when we're assessing risk of future cardiac events, we go through, at least I go through, a risk assessment using risk assessment scores. So there have been scoring, for instance, the Framingham Heart Score, which is a scoring system where several variables are put in, and then a likelihood of developing heart disease at an earlier age and a risk of cardiac events is then made. There are other scoring systems. The one that we're using more frequently now and has been recommended in the latest guidelines is something called the pooled cohort risk equation. Big fancy name, but again, it's another scoring system. So that's where it starts. It starts by knowing your family history, knowing your blood pressure, whether you smoke or not, what is your cholesterol, how old you are, race, etc. Once these variables are put into the equation, we then can assess for risk. Now, I will say, I think most physicians, myself for sure, when you hear about that premature coronary disease in a primary or first-degree relative, that really gets my attention, and I sort of really focus in and tend to get more aggressive with some of the interventions. The interventions are not necessarily doing 14 tests and a stress test and a cath. It's really about intensifying efforts at risk factor reduction and making sure you're following proper diet, proper exercise, not smoking, lowering cholesterol, and so forth.
Can you explain a little bit more about that? Because, I feel like I know people, I'm sure everyone knows someone, they had a member of the family die at an early age and they feel like, oh my gosh, that's going to happen to me. Can you talk a little bit more about, what do you have them do? What are the specific things you have people do?
Well, first, you like to get an assessment of, as I said, we assess risk to see, family history is one element of risk. And just because that family member had an event at an early age, the script isn't 100% written for you. Clearly, it needs to be addressed and put into the equation. What we tend to do is, assuming the patient does appear to have elevated risk, we would get very intensive in starting to lower cholesterol, tends to be with statins. We may do some testing to look for what I've termed earlier subclinical disease in the vessels that isn't severe enough to cause a symptom such as chest discomfort or shortness of breath, what have you. Based on those results, we may then intensify our lipid reduction further. If someone's smoking, clearly they need to stop smoking. Patients need to begin proper diets, limiting their saturated fats, limiting their cholesterol, limiting processed foods, weight reduction. I mean, one of the interesting things that I tell my patients is I find that people are concerned about their heart risk, and they're sort of looking for the thing. How can I prevent this? How can I make sure this doesn't happen to me? At the end of the day, if you can keep your waistline, at least in a woman, less than 35, if you can eat a proper diet that limits red meat, saturated fats, and cholesterol, if you get regular exercise, probably in the neighborhood of about 150 minutes per week, maybe 30 minutes a day, 5 days a week, if you do not smoke and you maintain acceptable blood pressures or relatively low blood pressures, you can prevent about 80% of heart disease over a lifetime. There's a big push now for lifestyle changes. I was just reviewing last month's one of the journals. The cover was "Get a Life, quote, style," and it was really all about these interventions. There's no sort of magic bullet out there. There's no magic test, and there's no crystal ball. You just have to, it's mostly just a lot of common sense.
No, I mean, that sounds like a recipe for a really good, healthy life for anybody. I just got another question in. It says, I'm a 56-year-old woman with no health issues except reflux and occasional asthma symptoms. Should I take aspirin every day to prevent a heart attack? There's a lot of talk about aspirin. What do you think?
There's a lot of talk about aspirin. Aspirin, is used in patients to hopefully thin the blood a little bit, prevent blood clots, and hopefully prevent heart attacks. To be very technical, the most recent guidelines that are put out, again, goes back to risk. At what risk level do we initiate aspirin? And according to the guidelines, if your risk is 6% or higher, aspirin would be recommended. Aspirin does tend to be overprescribed. It sounds like a fairly benign thing to do. However, there are downsides. There's bleeding risks and ulcer risks. Patients just don't tolerate it. But the party line would be if you have a 10-year, basically all the risk assessments are about 10-year risk assessments. If you have a 10-year risk that's 6% or higher, utilizing one of these risk calculators, aspirin would be recommended.
I'm curious, is everyone more at risk as they get older or not necessarily?
Well, no question, the incidence, I mean, coronary artery disease is clearly it becomes much more prevalent as we age. It's really a disease of aging. It starts oftentimes in your teens with, if you look into the microscope at blood vessels, you can see just fatty streaks, just some early accumulation of plaquing, which wouldn't cause a symptom, wouldn't be picked up on any test, and is really seen sort of under a microscope. And that can progress based upon various risk factors and will increase in severity or increase in its prevalence as we get older.
Can you reverse that? Let's say you were really unhealthy early on, and then you realize the error of your ways. Can you reverse what you did in terms of heart disease?
The answer to that is yes. The answer is yes. I mean, if a patient goes on a very rigorous diet, a very rigorous program, a very rigorous program of cholesterol reduction, studies have shown that that the plaques can recede. They are very intensive diets, often vegetarian diets, and often using very high doses of the statin agents. It's not always practical, it's not always attainable, and one of ways that I look at heart disease, again, it's we can live a long time with blockages, but we can't live a long time having heart attacks and strokes. So people get and patients get very involved with severities of blockage. Oh, I have an 80%, a 50%, a 90%, which is important. In my mind, it's important for the development of symptoms. But the real question is, how can I prevent the heart attack? Well, it turns out not all of these plaques are the same. Plaques are different. There are stable plaques and unstable plaques. There are sort of calcified, more mature plaques, and sort of very cholesterol-rich, soft plaques, which are more vulnerable to causing events. So I challenge the patients to sort of modify their lifestyle in the hope to take those more unstable, vulnerable plaques that cause events and sort of turn them into a more stable plaque that is less likely to cause the events.
Oh, this is very interesting, and I'm not. Forgive me. I've got a question here. What are PVCs and PACs? I have no idea what that is.
So, sort of new topic of heart disease. This would be in the electrical category. So PVCs stands for premature ventricular contractions, and PACs are premature atrial contractions. So a PVC is a extra heartbeat which originates from the lower chambers of the heart, and a PAC, or premature atrial contraction, is one that originates, an extra heartbeat that originates from the upper chambers of the heart. PACs are very common, as are PVCs. By and large, they tend to be benign. They tend to cause, in many patients, symptoms of palpitation and skipping and sort of maybe a flutter feeling in the chest. But for the most part, these, particularly PACs, are fairly benign, often triggered by too much caffeine, energy drinks, cardiac stimulants, maybe thyroid disorders. PVCs similarly can be caused and triggered by cardiac stimulants, tend to be benign, but when we see PVCs, which sometimes can represent more advanced stages of heart disease, we like to make sure that we have assessed the overall health of the heart, that the PVCs don't represent some other more significant underlying problem.
All right, doctor, I have to ask about this because a lot of people seem to think that stress has something to do with heart disease. Does it?
Well, the question of stress and heart disease has been out there for decades. I mean, back in the 70s, there was the whole talk of the type A personality, increased sensitivity to time and anger and short temper and so forth, that this was a cause of heart disease. And this sort of thinking has sort of gone in and out of favor. And more recently, there's been some data published and review articles that have come out that are sort of looking more at the roles of stress, and not just sort of generic stress, but actually different types of stress. You know, is family stress? Is there work stress? Is there personal stress? Sometimes it can get a little bit deeper into emotional stresses and maybe levels of stress that might lead to depression. And all of these things do tend to increase your risk. The numbers that they increase your risk by are relatively small, but I think there is a role for that. I think of a lot of the stress as more being a trigger for events as opposed to an active player in the creation and the progression of plaques. That is a debatable subject. I think there's more research that's being done in that area. Clearly there's an association. How to intervene with stress is sort of it's sort of a moving target. There are some recent studies that have actually shown that exercise can relieve stress and improve sort of heart health more than sort of antidepressants can.
And to that, we just got another question in. You were speaking earlier that 30 minutes of exercise a day, 5 days a week is something very good to do to help prevent heart disease, but we've got someone asking, is that really enough?
That is the minimum recommendation. So the minimum recommendation, and again, we're not training for, the Broad Street Run here. We're just trying to promote heart health. We're trying to create sort of a milieu in the body that is preventing heart disease and preventing cardiac events. It's not necessarily intensive training for major athletic events, but a minimum of 150 minutes a week of aerobic exercise is what's recommended. Sometimes there's been some recent publications, talking about marathon runners having an increased risk, and some people suggesting that maybe running marathons, may be more dangerous than maybe even being sedentary. So there is a bell-shaped curve to exercise, and we're all trying to find sort of the sweet spot. But again, 150 minutes minimum. Sort of use your judgment from there. What's the maximum? I think is going to be individualized in each case.
Okay. I'm getting more questions about food. You actually mentioned earlier, I think, some people would go to a vegetarian diet. Does a vegetarian diet actually give you a better shot at not getting heart disease?
So many people are overweight, and for the majority of the patients that I'm seeing, I think weight loss and minimizing their intake of processed foods and sugars and trans fats and saturated fats is really where they need to be. And I don't profess to be a nutrition expert. I'm a clinical cardiologist, and I really like to see my patients maintain a proper weight, try to keep the BMI 25 or less, and I feel as though any way they can achieve that in a healthy way is beneficial. I mean, a vegetarian diet may be more beneficial. There may be some benefits heart-wise, but maybe there's some benefits in cancer prevention. More protein-based diets may be a little bit easier to maintain weight loss in certain studies. But at the end of the day, I'm sort of looking for patients to maintain proper weights with healthy diets.
Right. Okay. A question just came in, and again, if you're just joining us, Dr. Andrew Fireman is a cardiologist with Abington Hospital, and this question just came in. How can you tell if symptoms such as indigestion or shoulder pain are something to worry about? I think a lot of people say, oh my gosh, what is this? We talked about this a little bit earlier, but when do you know you need to pick up the phone and call someone?
So a piece of me wants to say, when you figure it out, let me know, because
Yeah.
we face this. I mean, we as cardiologists and physicians and medical providers are always challenged by sort of the less typical presentations of heart disease, and is it heart disease or is it not heart disease? And oftentimes it's very, very difficult. So I think you need to sort of step back and sort of take a look at yourself. And first, at least the way I approach this is I look at the patient's risk factors and sort of try and put them in some sort of a category if I think they're a higher risk to have the problem or not. You can never be too safe. I mean, you don't want to cry wolf every time your shoulder hurts or you have some heartburn, but I think some guidelines might be if you notice that clammy, sort of sweaty feeling, that would really get my attention. If it's sort of increased when you're exerting yourself and it's sort of minimizing when you're more calm, I think that would be a concern that it was a heart manifestation.
Does it matter if it's something that's repeating itself?
Absolutely, because patients that have heart attacks, there tends to be some symptoms that preceded it. There tend to be some cardiac symptoms that may have occurred a day or two or a week before, a little stuttering course that's kind of in and out, and until they finally sort of show up having a heart attack. So if you see, I'm often looking for patterns and repetitions and similarities in some of the symptoms. Again, it's a very challenging space for providers. Obviously we never want to miss any heart attacks, but it is very challenging because the symptoms can overlap with other disorders that are more benign.
Okay. Another question just came in. Where do you recommend looking for advice on proper diet and exercise health? You've given us some great ideas. Is there a good place to go?
Well, I think you could go on abingtonhealth.org and there are dietary counselors there and dietary programs. I think for lots of patients that are looking to lose weight, I think the main thing is a program, something that educates and sort of arms the patients with knowledge, how to read a label, how to count calories, knowing what the proper caloric content is, not just sort of making a meal to meal decision. I think those types of things are going to be very difficult. You really need a plan and almost wake up every morning knowing sort of what you want to eat. And if that's going to be a diet that, a fad diet, that you picked up and it sort of makes sense to you and it seems to work. And I'm not talking sort of the, I don't know, some of the more outlying fad diets, but if you want to go to, you pick up a book and you saw the Sugar Busters diet or something, I think that, and that makes sense to you and you can maintain it and you feel like you have some knowledge, I think that's a reasonable way to go. I think Weight Watchers is always very good. Some patients, they're more successful with meal replacement. Dietary counselors, nutritionists, there's all kinds of different things, but I think the most important is a plan and advice and knowledge.
Right. I have to ask you about alcohol because there's so much on this. Some people say, oh, a glass is good for your heart. Obviously there's a lot of calories in alcohol just to begin with. Where do you stand on this? What do you tell your patients?
Sort of the party line, in my opinion, is moderate alcohol consumption is considered not necessarily directly heart healthy, but I think that that's sort of part of a healthy lifestyle, and I think that fits in to some of the category of behaviors and sort of states of mind and some of the stress side of the equation. I mean, too much alcohol is clearly bad for multiple reasons, and alcohol in large quantities is a direct toxin to the heart and causes congestive heart failure and weakened heart muscles. So that's clearly a problem to the one extreme. Abstinence from alcohol, if you choose, would be excellent as well, if that's what you choose. But I think a moderate consumption of alcohol is beneficial in terms of overall lifestyle and an overall healthy lifestyle from, I believe, multiple levels.
All right.
Not just a direct health to the arteries per se.
Okay. Here's a question that just came in. Can loud snoring be a sign of a heart problem? I haven't heard this before. Is it?
Kind of an involved question there. So loud snoring would often trigger a concern for sleep apnea. And sleep apnea is a condition where it's a disordered sleep pattern where patients will snore, and then often not breathe for periods of time, often seen in more obese patients, but often for various mechanisms can be in patients that don't fit the typical body habitus. So we'll go through these repetitive patterns of snoring and then not breathing and then drops in their oxygen levels. That in turn will cause secondary effects on your lungs and on your heart specifically, and can raise the pressure within the lungs and can cause stress on the heart, will elevate your blood pressure, can make you more prone for heart arrhythmias, for congestive heart failure, and so forth. So it sort of secondarily can affect the heart through reductions in oxygen when you sleep.
So it's really only if your loud snoring causes you to stop breathing.
Well, I don't want to go that far. I think there are multiple. I'm sorry?
No, I understand. Go ahead. Go
Okay.
ahead.
So I think, you know, if it's felt that you're snoring a lot, and maybe having these, what we call these apneic spells, which is the periods of time where you sort of stop breathing for moments when you sleep, the proper thing to do is to seek medical attention. One would often go for a formal sleep study and try to make a formal diagnosis. So not everybody that snores has sleep apnea, but it is sort of you know, the one symptom that sort of makes one get to a sleep study and maybe entertain the diagnosis.
Right. This is a question about heart disease related to cancer, or really more about cancer treatment. I'm a breast cancer survivor, and I know that I've been told certain treatments could impact your heart. Is that permanent? Can that be fixed? What's the relationship?
Several of the chemotherapies that are used for cancer treatment are direct toxins to the heart, and this is well known, well established, and is something that is monitored in treatment in cancer patients, oftentimes with either cardiac ultrasound or echocardiography, sometimes a nuclear medicine study, something called a MUGA study, which is a study that a nuclear medicine study that assesses heart function will be monitored to see if there have been effects on the heart muscle in terms of weakening the heart muscle. It's not so much a problem with developing heart attacks and blockages as much as it is with the heart muscle becoming weak and potentially developing congestive heart failure. So this is something that is more or less dose dependent and is tracked very carefully, usually by the oncologist. Many times when there are changes in heart function, you know, the chemotherapies will be altered. Medications can be given to promote healing of the heart, and often we can see improvement, but sometimes, unfortunately, there is an improvement.
I just received another question here. Do men and women have different experiences when recovering from a heart attack? I'm not sure. I would think it'd be kind of the same.
Yeah,
maybe,
you know,
maybe someone complains more than the other. I don't know.
You know, I think there's just individual variations. You know, there are people that, men and women alike, I don't think it's really gender dependent, where, you know, people get the heart attack and, you know, they have the epiphany, you know, they're all motivated and they're dialed in and they're you know, they're doing everything right, and there's other people that become very scared and may withdraw. There's patients that are, you know, not really certain. Certain patients kind of go with the flow and may or may not heed the warnings, or everyone, I think, is different and it's individualized, and I haven't really, in my experience, have seen major differences.
Sounds like the best reaction after a heart attack and after being treated is to get as healthy as you possibly can. I think that's what you've been saying. I mean, who's the best patient? I mean, after they've had a heart attack and you've treated them.
You know, it's very interesting. People, you know, will come to medical attention, you know, and their heart in several different ways. You know, many patients, you know, their first encounter with heart disease, unfortunately, is cardiac arrest, and they may not survive. Other patients may come in, you know, having a heart attack, you know, like red fox, here I come, Elizabeth, other patients, come just because they're having some symptoms. Once the diagnosis is made, it's amazing how well patients do that really begin a cardiac prudent diet, do not smoke, get regular exercise, take the proper medications, lower their cholesterol. It's amazing to watch these patients over time. By and large, nothing is 100%, how well they do and how well things work out for them.
Let's talk about it. You're having a heart attack. What do you do? What's the most important thing you do? And are there mistakes that people make? I've even heard studies about, those who can remain calm have a better chance of surviving. Is there anything to that?
Well, the most important thing is to somehow, some way, get medical attention to you, because when you're having a heart attack, there's this clock that starts ticking. And, the definition of a heart attack, the major heart attack, is a 100% occlusion of a blood vessel. And all of the efforts that are made, in treating acute heart attack patients is to open up that blood vessel as soon as possible. Sort of the magic number is 90 minutes, what we call 90 minutes first medical contact to sort of balloon time or opening of the vessel time. But anything less than that is only going to be of benefit to the patient. There's the old saying that we say, time is muscle. The heart's a muscle, and the longer that the blood vessel is occluded, the more heart muscle will be damaged. So the most important thing is to sort of not ignore it, to sort of, as rationally as you can, to say, I think I might be having a heart attack, and with your cell phone, 911 if you're alone, if you're with, is to get medical attention. And I think it's also very important that, if you're at home, do not drive yourself to the emergency room. Call 911, because things can happen in the throes of a heart attack. Your heart can stop, your heart can do all kinds of different things, and you don't want to be at the wheel of a car. So do not drive yourself. Call 911. And let the system work for you. The system is in place. It's been improved over time, and hospitals such as Abington and any other hospital in the region do amazing things to get those arteries opened up as quickly as possible.
That's great advice. Here's a question from a woman who says she's a 60-year-old female. She says, I recently had a chest x-ray for a pulmonary study, but it also showed coronary artery and aortic valve atherosclerotic calcification. I hope I said that right. Can you explain this, and is it something that is dangerous, or should I be concerned with it?
Well, when we see what we call coronary calcification, that identifies by definition that there is coronary artery disease. Now, how severe that disease may be is unknown. So you would need further testing or assessment to determine the extent of the problem or the severity of any blockage. But by definition, there is plaque there, and it happens to be calcified plaque. And most likely, there's other plaques in the coronary circulation that are not calcified and are there. This kind of information is often used to further assess risk in patients. So if you're, I forget the age, but if you're 60 years old and you have some high blood pressure and maybe there's some family history and your doctor has recommended, your cholesterol's up a little bit, maybe you should take a statin, and you're a little reluctant, and then you turn around and you find out, well, hey, I've already have coronary calcification. I already have the disease process in my vessels as evidenced by that x-ray. That, in my opinion, would often sway the patient to beginning the statin therapy and further intensify the efforts at lowering their risk by lowering cholesterol and hopefully modifying diet, exercising, and sort of partaking in a more healthy lifestyle.
I want to remind people who are just joining us that you can submit your question right now at any time during this chat via the submission box below. And again, it's anonymous, so don't worry. We won't reveal who you are. You can ask whatever question you want of Dr. Andrew Fireman. This is a health chat with Abington Health. Dr. Fireman is cardiologist, and this is brought to you by Philadelphia Magazine. What do you think, Dr. Fireman, what do you think the most important thing that people should take away from all of this in terms of, you know, I'm sure you're at parties where people say, oh, you're a cardiologist, you know, what is the most important thing I need to know about heart disease?
Again, I hate to be repetitive and I hate to sort of sound like the broken record, but I think, as I said earlier, men, keep your waistlines less than 40 inches. Women, keep it less than 35 inches. Try to minimize, maximize fruits, vegetables, nuts, and good proteins. Try to minimize your processed foods, and if you can, eliminate saturated fats. If you're smoking, stop. If you're diabetic, make sure you manage your diabetes and keep your weight down. Get your cholesterol checked. And possibly intervene if it's significantly elevated or you have high risk, and get your regular exercise. And you can take care of, some people believe, upwards of 80% of the problem.
Right. We just got a question about caffeine intake and wondering if that affects the risk of heart disease. And you know, there are all these energy drinks too. Is that anything that we should be concerned about? Is there a limit to how much caffeine you should have, or does that affect the heart?
Well, I see a lot of the energy drinks, excessive caffeine, presenting predominantly in younger patients that are coming to cardiologists with a lot of palpitations and chest pains and irregular heartbeats and maybe altered sleep patterns, and and I sort of ask those questions, and often we'll find out that they're drinking, 4 or 5 20-ounce lattes a day and whatnot. It's quite striking, actually, sometimes when you get these histories. But I think of it more along those lines, and I often will take that opportunity in patients to say, look, this isn't good for you, it's not making you feel well, but why don't we focus on some of these other things? Look, you're 20 pounds overweight. Your blood pressure is not quite where it should be. It's time you started taking things seriously. I know why you're here, but really you're missing the boat here. You need to cut down on your caffeine, maybe even eliminate it altogether. But let's go start focusing on your diet. Let's start focusing on not smoking. Let's start focusing on exercise.
Like, can caffeine cause heart disease, or is it really one of those things that may cause symptoms, and as soon as you quit, you're
I think it's more the latter. I think it more will cause a lot of concerning symptoms. I'm not aware of it being a direct cause as a significant risk factor for the development of heart disease. It's not part of any risk score, what is your caffeine intake and so forth. I'm more of a broad stroke. I think people get focused on, they're looking for the little nuances and trying to sort of get that one thing that's going to make everything go away, and really it's the big picture that I think people often miss. And because the big picture is hard. It's hard to lose weight. It's hard to exercise every day. It's hard to not eat that cheesesteak or that burger or that pizza when you want. It's hard, and we all have to deal with it, but at the end of the day, that's kind of where you need to be.
I got to ask you a question. Sometimes you eat a meal and it's heavy in fat, and can you actually be impacted by one really bad meal, or is it cumulative?
Well, clearly it's cumulative. I
don't know.
I would have to go look that one up to see if one meal. I'm sure it's been out there.
They talk about the cheesesteak as a. Never mind. All right. Okay. Here's a question from a viewer. I'm 70 years old, and I've been diagnosed through an echocardiogram with a moderately leaking aorta valve. I'm taking Zocor, 10 milligrams, one a day, and Visipa 1 gram 2 a day. I've been doing an hour of cardio exercise 3 times weekly for the last 8 years. It says I'm very active, depending on whether I'm playing golf or bowling 2 times a week. My stress tests are normal when they stop me. All right, so how's he doing?
Well,
The cardiologist is, all right, so he says a cardiologist is following yearly. What else can I do to address heart problems? He says no symptoms.
okay, so I mean, this is one element of heart disease that we really haven't discussed, and that's valvular heart disease. So this patient has what I believe is somewhere, I think it was described as a moderately leaking aortic valve, which
Right.
is a fairly common condition. And really, you know, I think why the valve is leaking is important in that for certain sort of specialized cases, you know, is there something specifically genetically wrong with the valve, which is important to know. But assuming it's a fairly normal or early degenerative valve, really what one is doing in that situation is trying to determine when or if or when there's a time to fix the valve, to replace the valve. And that is really, to keep it simple, based upon, for the most part, one of two scenarios. Either the patient is developing symptoms of a leaking heart valve, which would be effort-related fatigue, shortness of breath, symptoms of what we might call congestive heart failure, which can be very insidious. Oftentimes it's not, you know, in this kind of more chronic situation, can be very slow, and you really almost have to think back, how did I feel a year ago, and, you know, how do I feel now, and there's a change. So symptoms in a significantly leaking valve would then maybe direct the patient to a surgical evaluation. And then echocardiograms are done every year, 2 years or so, to assess various dimensions of the heart. There are certain cut points where valve surgery is recommended if the heart starts to enlarge to a certain degree, if the heart function starts to reduce or change. I can tell you with aortic insufficiency or aortic regurgitation, the heart tends to tolerate that very, very, very well. And it tends to take a very, very long time for those patients to come to surgery with that particular lesion. It tends to be a very well-tolerated lesion.
Okay. Another question just came in. If you can't take a statin, do you recommend anything else to lower cholesterol?
Statin intolerance is a huge problem. You know, a lot of patients fear the statins because of side effects, a lot of muscle aches and pains, which I often think the patients sometimes tell us that because they just don't like taking them. And there's a lot of other reasons why they might have aches and pains. But that aside, for whatever reason, I'll still try and have patients take statins if I feel they really need them. And specifically those patients that already have diagnosed heart disease. Those are the ones that are going to benefit the most from statins and from cholesterol reduction. So I'll often try to back off the dose and start at very, very low doses, half pills every other day, and go very, very gradually, because for the most part, those are the most effective and easiest medications to take for cholesterol reductions. The other medications, such as what we call the bile acid sequestrants and cholestyramine, ezetimibe or Zetia, which is not a statin but can lower cholesterol, are not that powerful and have their own set of side effects as well. The data is just so good on statins that I try and just get the patients to do the best they can with it and accept the best that we can, because I think that's where they're going to get their greatest benefit.
Okay, Dr. Fireman, Dr. Andrew Fireman with Abington Hospital, cardiologist. You've given us so much wonderful, great information. If you wanted to leave us with one last thought very quickly, what would it be?
Well, I've said it 3 times, but let's eat right, not smoke, get some exercise, and keep our waistlines in check. And I think the other one is, this is going to be sort of a shout out, and she'll know who she is, but early heart attack care. I think, we talked on it before. If you think you're having a heart attack, don't delay. Seek medical attention. Call 911. Don't drive yourself. Get to the hospital, and let the providers do what they can do, from the emergency room to the nurses to the EMTs to the docs to everybody that's involved in that process. It's very coordinated, and it could save your life.
Dr. Fireman, thank you so much. I want to remind everyone that our chat is on Tuesday. The next chat is on Tuesday, March 24th at 6 p.m. with Dr. Andrew Starr. He's the medical director of Abington Health's Orthopedic and Spine Institute, and he's going to answer your specific questions on knee pain, both conservative and surgical treatments for knee pain, and he'll be educating us on Macoplasty, a highly advanced and minimally invasive knee surgery to relieve pain caused by osteoarthritis. And you can sign up and ask your questions ahead of time by registering on www.abingtonhealth.org/healthchats. Thank you so much for joining us. We've enjoyed it, and thank you to Philadelphia Magazine for hosting. Have a great evening.
This is live.